So there are several options of immunotherapy: cell-based immunotherapy, antibody-based immunotherapy, and vaccination in theory. So cell-based is CAR T cells, for instance. CAR T cells are developed against certain antigens on myeloma cells, on BCMA. They have been shown to be, these CAR T cells, extremely active, and two companies at this point of time are working on this project together with scientists to bring it into the clinic as soon as possible. This will be fantastic. Other approaches to modulate the immune system are very important, just to downregulate the T regulatory cells and to activate the T cells, killer T cells and so on. It will be important. We will understand it better in the future, and we'll have even antibodies which interact with Tregs, for instance. Antibodies per se have changed the treatment paradigm, because they are already part of an important part of relapse refractory therapies, and they will become part of first-line treatments. And so we'll change our treatment paradigm from a poorly conventional treatment backbone to a combination of this backbone plus antibodies. And it may be that we use 2 antibodies or even 3 in the future. These antibodies can be, of course, coupled with toxins, can be made more active. You can have antibodies against cell antigens, myeloma cell antigens, against antigens on the stroma, and particularly against epitopes which hinder the immune system, which block the immune system, these so-called checkpoint inhibitors. And a combination of checkpoint inhibitors with antibodies against tumor antigens or myeloma antigens seems to be very feasible and useful. In addition, vaccination is another choice, and if that would work, we would vaccinate in the future every patient with MGUS or smoldering myeloma, which vaccines are presently under investigation. Vaccines which use which use proteins which inhibit apoptosis of myeloma cells, which, for instance, BCL2, BCLX, or BCL1. These are proteins which allow the myeloma cell to live forever. So if you can reduce these proteins, myeloma cells are prone to die. That is the hope. And actually there are in vivo data which have shown that this might be feasible. You can use vaccines against PD-L1. These are the proteins which inhibit T-cell response. So then you vaccinate your patient, he produces his own PD-L1 antibodies. You don't need an antibody to administer every 2 weeks or so. So this is also fantastic. So, in the end, I think modulating the stroma will be very important and will help us to enhance the activity of our conventional therapy.
There are many promising new agents for the treatment of myeloma patients. And after the proteasome inhibitors and immunomodulatory drug that arrived to the myeloma more than 10 years ago, we had second-generation PIs, and we had second-generation immunomodulatory drugs, and even monoclonal antibodies. But in addition, we have also new agents with a different mechanism of action. One example is venetoclax, an anti-BCL2 and BCL2 inhibitor that have demonstrated to be very effective as single agent in relapsed and refractory myeloma patients having a specific translocation, 11-14 translocation. In addition, venetoclax has been also combined with bortezomib and dexamethasone, and the results, although preliminary, very encouraging in patients after 1 to 3 prior lines of therapy and bortezomib sensitive. And in fact, there is currently ongoing a phase 3 randomized trial comparing bortezomib dexamethasone versus bortezomib dexamethasone plus venetoclax, and this 3 drug-based combination will be probably a new standard of care. Another promising new agent is selinexor. It's an exportin 1 inhibitor also a new drug that has demonstrated to be effective as single agent in patients refractory to proteasome inhibitor, refractory to immunomodulatory drugs, and also refractory to the monoclonal antibodies. In this setting, 20% of the patients responded to selinexor single agents, and this has been the rationale to be combined with proteasome inhibitors. And again, there are preliminary but encouraging results of selinexor in combination with bortezomib and dexamethasone, and there is also a phase 3 trial currently ongoing, and probably selinexor will be incorporated to the treatment armamentarium for our myeloma patients. In addition, there are another new agents like ibrutinib, or even new compounds that are going to target specific mutations or specific abnormalities present in patients with myeloma, but the results are immature yet, and we have to wait to have more consolidated results.
A lot has changed with myeloma in the past decade, and I think based on what we see today, a lot more is going to change in the coming years. It's a combination of understanding the biology of the disease and also understanding how the disease and why the disease behaves differently in different people is going to be the key for adapting treatment in patients with myeloma. So I think the next few years we are going to treat patients with myeloma differently based on their underlying genetic characteristics. So I think there is certainly a case to be made for not just risk-adapted therapy, but more personalized therapy in myeloma based on a better understanding of the biology and the mechanism of action of individual drugs and combinations. We'll have a lot more choices. We can treat patients to a deeper response. We can treat patients longer to keep them in that deeper response and potentially curing some of these patients of the disease. The safety of these new combinations will allow us to use the drugs early on in the course of disease, potentially in patients with high-risk smoldering myeloma, again increasing the probability that we will cure some of these patients. And the ability to give these drugs longer term without a cumulative toxicity also will improve the overall quality of life for patients.
I consider that although myeloma remains today as an incurable disease, I think that we are going to be able to offer the cure, if not to all, to some patients with multiple myeloma. This is going to be based, of course, on the novel agents-based combination that are emerging for the treatment of patients with myeloma. All these new combinations, very effective and with excellent toxicity profile, are being evaluated in late advanced stage of the disease. And in this situation, this combination resulted effective. So the optimal way is to move with these new regimes to earlier stage of the disease, and probably we have to move to the newly diagnosed. And when all these new combinations based on proteasome inhibitor emits corticosteroids plus monoclonal antibody are going to be administered at the moment of diagnosis, I think that we will be able to offer the cure for some patients with myeloma, probably for standard risk patients. Probably we have to continue investigating in patients with high risk features, because these patients continue being a relevant challenge for us, but most of patients we have in our clinic every day are standard risk myeloma patients, and I'm completely sure that we will be able to offer the cure.
So what is important for the future? We need excellent research. We need very good cooperation between pharma and medical scientists. But we also need the support of patients, and the patients need to be involved. They need to engage themselves, because the more they know about the disease, the better they are able to react when they face complications. So we always say patients in low socioeconomic categories or classes are handicapped because of lower income. This is not the real explanation in Europe, because all patients here in Europe have access to I think, reasonable medical care. But you have to have a brain which helps you to react, which helps you to understand, which helps you to interact with your care team, which helps you to get the best out of the options which are available. So you have to be active, you have to understand that. And so people have different, let's say, talents and personalities, and not everybody has these features which are needed to make out the best of the options which are available. So that is something patients should know about. Because sometimes patients come in and say, I feel bad, I have bone pain, but are not prepared, do not ask themselves, what do I want to get out of this conversation, of the consultation? What does the doctor need in order to give me his best choice, to make the best decision for me? So that is something. So we have, actually, the future is bright, but we have to be aware that all parts involved in the care, including the patient, have to be active as possible and have to contribute.